Assalamu alaikum warahmatullahi wabarakatuh. Today I'm going to be explaining a little bit about the anti-anginal drugs. It's a bit of not a hard lesson whatsoever, just takes a little bit of concentration. And inshallah, if you really, some of these lessons really depends on if you study pathology, biochemistry, maybe a little bit of microbiology if you need to, but mainly pathology and microbiology to get an idea of the anti-anginal drugs that are used for angina pectoris and also for other diseases as well. It's like myocardial infarctions, some types of heart failure, and other diseases as well. Okay, so we're going to begin with angina pectoris. As we know, angina pectoris is a clinical syndrome due to myocardial ischemia. Angina as in chest pain, and pectoris as in chest, so chest pain. Now, there's a pain occurring in the chest. Now, here's the thing about angina pectoris is that what I'm going to do is that I'm going to draw all of the types of angina pectoris. So let me go ahead and draw it. This is a blood vessel. This is another blood vessel. This is another blood vessel, but hold on. We're going to draw it like this, okay? And then what we're gonna do is that we're gonna draw what is known as the aceroma growing out of the intima. Okay, here's gonna have an aceroma, but this time we're gonna have a little bit of a twist. We're gonna have a little bit of a twist here. We're gonna draw this purple, and actually, you know what? Let's have this purple. Let's have this purple protruding. Okay. Let's have it protruding. And this one we're going to leave it alone. Okay. So what I got here is basically as three types of angina pectoris. Okay. And if you studied my pathologies, then you already know what are these types of pectoris just by looking at the picture. Okay. Now what I'm going to do is going to take this red color. I'm just going to have RBCs. I'm going to have RBCs just going around this aceroma and going around this, what is known as coronary artery spasm in this one. Okay. And we're going to keep it for now. We're going to keep this. Now let me get the eraser real quick. Just delete some of these. Perfect. Okay, so what do we have here? We're going to draw it in the black color. So here's the thing about angina pectoris. The reason there is angina pectoris is because usually pain occurs as a signal from your body. And in the case of coronary arteries, when there is usually ischemia, and when we say ischemia, we say deficient blood supply to an organ, like let's say the heart, your heart is going to send pain signals that, hey, I'm not getting enough oxygen. So let's see what's going on here. Usually angina pectoris comes as a result of something blocking the coronary artery. So let's say, for example, this is your heart. Okay, let's say this is your heart. And as your heart contracts, whenever your heart increases its heart rate, its contractility, whenever there's increase in the diastolic volume, ventricular volume, whenever there's any scenario in which your heart is going to have an increased something off and is going to need increased consumption of oxygen. Why oxygen? Because it needs oxygen for synthesis of ATP and aerobic metabolism. Okay, so it depends on oxidative phosphorylation. Now, usually, this is called as myocardial oxygen demand. Okay? We got oxygen demand. And then we're going to type right here oxygen supply. Okay? Now here's the thing about oxygen supply and oxygen demand. Oxygen demand, or let's say consumption of oxygen, increases whenever you're doing these activities or whenever you're not increasing anything. Whenever there's an increase of heart rate, whenever you have to contract, whenever your heart has to do anything, eject the blood, all of that requires oxygen, all of that requires ATP. Now usually when the heart contracts and pumps its blood to the aorta, and then the aorta supplies the heart with its two coronary arteries, when it contracts and basically ejects the blood, it basically expects the coronary artery to meet with the demand. So whatever this demand is, the oxygen supply or your coronary arteries are going to supply the heart with sufficient amount of oxygen. Okay, so usually normally Whenever the oxygen demand increases, so will the supply. So will the oxygen supply, or let's say delivery from the coronary arteries through vasodilation. Okay? And usually they're equal because your heart has to compensate. Now, here's the thing. Let's say there's still an increased oxygen demand. However, the oxygen supply, meaning these arteries, the oxygen supply or the oxygen it sends towards its heart through left and right coronary arteries are not sufficient enough to meet with this demand. So, there's going to be release of vasomediator substances, which will indicate that there is not enough oxygen being supplied, and this will lead to what is known as angina pectoris. And usually angina pectoris is followed by, which eventually was ischemia, that is, usually followed by myocardial infarction if it progresses soon enough, and other types of complications as well. Okay? Now, usually angina pectoris usually occurs before myocardial infarction, ideally. It's usually a warning sign. So we want to treat this angina drug and we want to prevent myocardial infarction at the same time. So when we look at these blood vessels right here, when we look at these blood vessels, and I'll get the green color, we're going to see three types of angina pectoris, okay? We got the first one, which is exertional angina or stable angina, same thing. And this type of angina is usually triggered by physical activity. So you'll have pain that activates whenever there is exercise, whenever you're doing anything that requires increased oxygen demand. And it usually is relieved by rest. Why is that? Well, you see, the cause of exertional angina is due to formation of atherosclerosis or atheroma that is undisrupted. It hasn't ruptured or anything. It's just growing and it keeps growing and growing. Now, at rest, your heart could adapt to it. There'll not be any pain. If it was blockage of, let's say, 50% of the lumen, your heart may be just fine, okay? During rest. However, when there's exercise or when you're at an emotional stress, there's going to be increased amount of oxygen. There's going to be increased heart rate. It's going to require more oxygen than usual. And unfortunately, this amount of blood supply is not enough. It's not going to meet the demand. So there's going to be what is known as stable angina. Called as stable because the pain is stabilized by rest. The second one is known as unstable angina, in which the pain is more frequent. And not only is it more frequent, let's say usually typical pain lasts for 15 seconds to 15 minutes. It may last up to more than 15 minutes, let's say 20 minutes. And it lasts for more than that, and it lasts, now let's say not lasts, it becomes more frequent than stable angina. And this unstable angina, it differs quite a little bit from stable angina, in which it will have atheroma in the blood vessel. However, the atheroma, it ruptures, and there will be formation of a thrombus, and there will be formation of a partial thrombus. And this will block the lumen a little bit further. Let's say 80%. And therefore, what's going to happen is that the oxygen supply, no matter what, is not going to meet the demand, whether at physical activity or during rest. So this is usually a sign, not just unstable angina, but also a sign from unstable or stable angina, in which there might be occurrence of myocardial infarction if it's too late. The last one is vasospastic angina or Prinzmetal variant angina, the same thing, in which there is no formation of atherosclerosis blocking the coronary blood flow. Instead, what's happening is that there is a probable cause in which, let's say, platelets. You know how platelets, when there's injury, they release mediators that do vasoconstriction. For example, too many platelets could do vasospasms, and basically no formation of atherosclerosis, but instead there'll be severe vasoconstriction, which will block the coronary blood flow. It's going to decrease the amount of blood that can flow through, and this will be characterized by pain either way, during physical activity or rest, and is usually characterized by episodic pain. When it says episodic pain, I need pain that occurs within a certain time of day. Every day somebody gets Prinzmetal variant angina during the night, every day, okay? And you will see that when we continue that there are drugs like beta blockers that we cannot use whatsoever on this angina, and you'll see later on. But for now, what did we learn? We learned that the angina pectoris comes in three patterns, And what they all have in common is decreased coronary blood flow. And this is bad, because if there's decreased coronary blood flow, there's going to be decreased oxygen supply to the heart, which means it will not meet, or it will not live up to the oxygen demand or the oxygen consumption that the heart used for its contraction. So what is our goal with angina pectoris? As we look at the next slide, our goal is to prevent angina pectoris or to treat it. Okay, so prophylaxis, or we can acute treat it. We want to prevent angina pectoris, and we could also avoid other scenarios like myocardial infarction, like heart failure, like for example cyanoid poisoning in nitrates. We'll look into it later on. So we're going to look at many of these factors that help become avoided. A lot of scenarios, a lot of diseases that could be avoided by using anti-anginal drugs. There are three. There are beta blockers, there are calcium channel blockers, and there is nitrates. These are the main anti-anginal drugs, and what they all have in common is that they will do what? They're going to decrease the oxygen demand. Now, usually, Shabab, when the heart gets damaged, it's like the neurons in your brain. Once they get damaged, they can never ever regenerate. They're not like your skeletal muscle, they're not like your smooth muscle. They have no regenerative ability. So once they're damaged, they're permanently gone. So usually with people with heart problems, basically what these anti-anginal drugs do is that since your oxygen demand is still increased and your oxygen supply is permanently decreased, because we said before, if there's any damage to the myocardium due to necrosis or ischemia, then we're gonna have to compensate by decreasing the oxygen demand. So because of that, people with heart problems, when we give them anti-anginal drugs, they're at these drugs for the rest of their life, and they're gonna have to limit their exercise and so on. So this oxygen demand, decreasing it is unfortunately something that we have to do in order to save a patient's life. Okay, so we said that what these anti-anginal drugs do is that they all decrease the oxygen demand in order to be equal to what? The oxygen supply. Make up for it. Okay, this is their goal, to be equal. So before we go to the drugs, let's look at the scenarios in which myocardial oxygen demand increase, like we said before. Increased heart rate, this needs energy, increased contractility. When we say myocardial contractility, I mean the strength of contraction. How hard can it contract? What is the strength of contraction? Of course, this requires more energy. Peripheral resistance, you could say this is the afterload or the blood pressure on the coronary arteries. Ventricular volume, EDV. Ejection time, basically remember in cardiac cycle, rapid ejection phase and slow ejection phase. Basically, when there's an increased amount of EDV, let's say 300 milliliter, it's gonna need more energy in order to eject, let's say 300 milliliter, and it needs to excrete or eject 270 milliliters. The heart will need to consume even more oxygen. It will need to consume more ATP in order for what? To increase this ejection time so that it can be able to excrete, or let's say eject, all 270 milliliters of blood from the ventricle to the aorta. So that's another scenario. And what we look to do is that once we look at these scenarios, is that we look for drugs that act in some of these. Like for example, nitrate will act on the ventricular volume, it'll act a little bit on the contractility. We got beta blockers and calcium channel blockers that will act in these and these and these. Tamam. So you want to act on these and decrease them so that the demand decreases and so that the oxygen demand is equal to the oxygen supply in the coronary arteries. Okay? So, okay, here's one more thing before I go, is that usually the only way, in a normal pathway, when there's nothing wrong with the heart, is that normally in order for the heart to increase its oxygen supply to meet up with the oxygen demand, normally like an exercise tachycardia, is by augmenting the coronary blood flow, increasing the coronary blood flow. And one of the ways to increase the coronary blood flow is, what are the factors affecting it? Pressure. So what you could do is that due to tachycardia, eject more and more blood towards the aorta. The pressure in the aorta will increase, so that when during diastole, for example, let's say the aortic pressure, instead of 120 during exercise, it becomes 140 due to more ejection of blood. And this 140, this is going to be more pressure in the aorta compared to, let's say, 0 in the ventricles during diastole. So what's going to happen is that, as we know in common sense, in order for blood to flow from one end of the vessel to the other, there has to be pressure gradient. And the greater the pressure gradient, the greater the pressure difference, the greater the blood flow. Tamam? Or the greater the movement of blood towards the other end of this vessel. And usually we can do what? Vasodilation to increase the blood flow as well, and include the volume of blood and inject more blood to the aorta at the same time. Okay? So now that we looked at all of these, we understood what is the purpose, what is angina pectoris, why does it happen, and what are the scenarios in which angina pectoris could basically happen, and what we need to do to fix it. So now, let us look at the drugs. Let us now look at the drugs. And I also recommend looking at the notes as well. Very, very useful. You might not even need to read them, but they're very useful. So, let's look at the drugs that we will have to use for anti-anginal drugs to treat angina pectoris. And these three drugs are simply nitrate, calcium channel blockers, and beta blockers. Look what they at least all have in common. They all decrease the oxygen demand so that it's more equal to the oxygen supply. But you realize something, right? They decrease the cardiac oxygen demand in their own way. And we will see in each drug that some of them may be similar to one another. Some of them have their own main action. They have their own mechanism of action. And some of them have an additional action other than treating angina pectoris. Some of them, you'll see, that act on other things. And we'll look into it. For now, just know that we're going to look at these three drugs for the rest of this lecture, and we're going to see why. Okay? So basically, when you finish pharmacology, I want you to go and look back on this table again. This is pretty much going to be your summary. A little small summary, tamam? So now we look at the nitrates, and let us go ahead and erase some of these. Let's go and clear all of these, okay? And let us draw the endothelial cells, okay? So I'm gonna draw the muscular artery. You remember intima, media, and ventagia. We're just gonna draw the intima and the media, okay? So this person is gonna be your endothelial cells. And this process right here, we're going to draw it very big, all right? These tiny dots, Shabab, are going to be your smooth muscle cells. Just give me 1 second. And I'm going to draw an arrow to zoom what's happening. Actually, no. You know what we're going to do? We're not going to do any of that. To make it much more simpler, we're just going to draw one big smooth muscle. So, let us get... And let's draw it in... let's draw it in a red color, okay? Let's have it right here, okay? Let's draw it just one more time. Perfect. Now what we're going to do here is that we're going to take, this is your intima. This entire thing right here is your intima. I put it as I, and this is your media. Okay? What does intima contain? Endothelial cell and this plasma membrane, this open plasma membrane. What is next to it? The media, which consists of smooth muscle cell. This circle is just one single smooth muscle cell, okay? So I'm going to draw right here. Let's draw right here smooth muscle cell. So just so you know. And let's draw here endothelial cell, EC. Okay. Let's get the green color. Okay, so the first drug we're going to have in mind is nitrate. But before I go to nitrate, let me talk about the normal metabolism that occurs, how vasodilation normally occurs in your body, and then we'll compare it to the nitrate and what it does. It will be much simpler. So normally, Shabab, as you guys know, there are three types of nitric oxide synthesis in the endothelial cells. There's inflammatory, there's neuronal, and there's endothelial. Endothelial cells have an enzyme called nitric oxide synthase, which turn Arginine into nitric oxide. Nitric oxide is a free radical. Why do we need it? Well, first of all, this free radical has a very short half-life, and fortunately this free radical doesn't cause much harm because it has only one purpose, and that's to cause vasodilation. How? Let's look at this journey. For first, let's say arginine gets turned into nitric oxide, okay, by ENOS in the intima. It will synthesize this nitric oxide, and this nitric oxide will travel from the endothelial cells all the way to the media, to the smooth muscle cells. Okay? Now, before I talk about what it does next, let's talk about the normal, the normal mechanism of smooth muscle contraction. So you guys remember, and let's draw this in a very small text. So you guys remember smooth muscle contraction, MSK, how it occurs? There's the myosin, and let me draw it in another color. So there's the myosin, and here's the actin. The myosin and the actin. And normally how smooth muscle contraction occurs is not due to troponin. You know, in skeletal and cardiac muscle, in order for muscle contraction to occur, calcium has to bind with troponin, then blah blah blah. There is cross binding between actin and myosin. In smooth muscle is different. So usually calcium comes in, and calcium, once it enters the smooth muscle cell, it will bind with something called calmodulin, and it will form a calcium calmodulin complex. Okay, let's type right here so we don't have much space. We'll see CC. CC for calmodulin complex. This calcium and calmodulin complex together is going to activate a very important enzyme known as myosin light chain. Let's say myosin light chain kinase. And what this myosin light chain kinase does, it adds a phosphate group to the myosin head. And it just so happens that the only way smooth muscle contraction can occur is through adding phosphate to the myosin head. So once myosin light chain kinase phosphorylize the myosin head, what happens is the myosin is going to be activated, and there will be cross binding. There will be muscle contraction. Now, what is the reverse? Well, how can we do vasodilation or dilation of the smooth muscle, relaxation of the smooth muscle? Well, this is where nitric oxide comes in. What nitric oxide does, and we're going to write it in the green color, what it does is that usually, instead of phosphorylation, it comes in. It comes in, and what this nitric oxide does, it will synthesize a very, very important enzyme in the smooth muscle cell, or let's say activate a very important enzyme in the smooth muscle cell known as guanyl cyclase. Guanyl cyclase. And what this enzyme does is that it will activate the synthesis of something very, very important, which is CGMP. So it's in the slide as well, CGMP. And what the CGMP does, it will activate a very similar enzyme to myosin light chain kinase. The only difference is the exact same thing, but the only difference between myosin light chain is the name. We'll say here, let's get the black color. We're going to say he's going to activate. So CGMP is going to activate the enzyme myosin light chain phosphorylase. So there's myosin light chain kinase does phosphorylation. What are you saying myosin light chain phosphorylase does? It dephosphorylases. It removes the phosphate group from the myosin. And what happens to the myosin? It will detach from the actin. There will be smooth muscle contraction. Smooth muscle relaxation. Sorry. So what did we learn? Is that nitric oxide, other than having two functions, if you guys remember from biochemistry, which is inhibit platelet aggregation, and the other one was to inhibit proliferation of smooth muscle cell. Its main function is vasodilation. So this is what I just explained is what normally happens in your body. So what we can do is that the exact same thing is gonna happen. Almost the exact same thing. Is that except the difference, right? Is that instead of nitric oxide being naturally synthesized by the endothelial cell, we have a drug that is exogenous that can do the same effect as nitric oxide. Now remember, before I talk about the drug now, is that nitric oxide, when it causes vasodilation of the smooth muscle, it causes vasodilation of anything that contains smooth muscle. So not just the walls of blood vessels, any smooth muscle in the respiratory muscle, in the GIT, in the genitourinary tract. It's non-specific. It's non-selective, okay? So we're going to see there's some side effects to it, and we're going to see why it also inhibits platelet aggregation. It's related to guanyl cyclase. And my bet for this enzyme should be G. Okay? So this is the normal metabolism. What is the difference now that we use something like nitrate that does pretty much the same end goal, muscle relaxation, vasodilation, okay? So let's look at these. We got drugs, examples of drugs that you need to know: nitroglycerin, amyl nitrite, isosorbide mononitrate. And basically, I'm going to draw on the right. Basically, what happens when you take the drug is that these nitrates, these nitrates are going to be denitrated by an enzyme called glutathione S transferase. Okay, and this glutathione transferase it's gonna convert nitrates into free nitrite ions with an I. Okay, so we're gonna say FNI stands for free nitrite ions. Now, glutathione S transferase, when it converts nitrates into free nitrite ions, it requires the reaction of sulfahydryl groups, which it gets from endothelial cells. So it requires the sulfahydryl group as a catalyst in order to convert nitrates into free nitrite ions. Then these free nitrite ions are going to be converted again into the nitric oxide that we know by the endothelial cells. It's not mentioned, but it's by the endothelial. These free nitrite ions go to the endothelial cells, and what they do is obviously convert free nitrite ions into free nitrite ions by endothelial nitrate synthase. My bad. This here, endothelial nitrate oxide synthase. There we go. So free nitrite ions is going to be converted to nitric oxide by endothelial nitrate oxide. I forgot the name. Endothelial nitrate oxide synthase. There we go. And then this nitric oxide, what this is going to do the exact same thing. But one more thing is going to require another sulfahydryl group, SH group. Why? Because it needs the sulfahydryl group, this nitric oxide. It needs it to activate the guanyl cyclase. So here it needs an SH group twice. And this is relevant to nitrate tolerance, one of the reasons for nitrate tolerance later on. And of course, what I explained everything here is going to be the exact same thing. So what's the difference between normal metabolism of nitric oxide and this one? Basically, instead of endothelial cells directly synthesize nitric oxide, we can have this drug, take it, pretty much denitrate it, and then immediately turn it to nitric oxide. Okay? That's the only difference. And they do the same effect as I explained before. Now, if we go to the next lessons, let's delete some of these real quick. And let's proceed. Okay. Now let's see what happens. The effect is, as we said before, smooth muscle relaxation everywhere, by the way. Not just in the blood vessels, but everywhere. And if you want to know, is that it causes smooth muscle relaxation mainly in the veins, in terms of blood vessels, mainly in the veins. And also nitrates can do one in the arteries, but mainly it will be on the veins because it contains more guanyl cyclase enzyme than the arteries, okay? And what are the other effects that it has is, of course, this guanyl cyclase is also found in the platelets. So usually what happens is that if there's high amounts of guanyl cyclase rolling around the smooth muscle, pretty much your body's going to think that, hey, this probably is probably because of the cause of platelets, which contain this enzyme as well. So endothelial cells are going to synthesize nitric oxide to also inhibit platelet aggregation. So it's another effect of it that it can inhibit platelet aggregation as a result, due to high levels of guanyl cyclase. And also an effect, and this is related to nitrate tolerance, one of the possible reasons, which is a decreased availability of tissue sulfahydryl groups. And why? Because we need sulfahydryl groups, not one but two reactions. So let's say if a person, overdoses or increases the dose and frequency of nitrates, he's going to deplete these tissue sulfahydryl groups. And unfortunately, we need these sulfahydryl groups to finally synthesize nitric oxide, right? And give us relaxation of smooth muscle. So without them, this will pretty much reduce the action of nitrates, at least partially. It will inhibit or put a hindrance on its effectiveness, okay? We'll look into it more. So these are general effects, but let's go and look at the actual effects. What does it do exactly? And how does it help in angina pectoris? So we said before that all the anti-anginal drugs, what they all have in common is that they decrease the oxygen demand so they can be equal to the oxygen supply. So let's look at what nitrate does and what nitric oxide does to the blood vessels. So here's what I'm going to do. I'm going to write here, you know what? I know there's four pulmonary, I'm going to have the pulmonary vein. I know there's four of them, but I'm just going to write one for simplicity's sake. Here's your superior vena cava. Here's your inferior vena cava. And here we're going to draw the aortic, pretty much the aorta with its aortic valve and here is gonna be your gonna be your tricuspid valve. We're gonna draw the heart real quick to see the effect. Okay, and here is gonna be basically your ventricular septum. There we go. Now let me draw this. Let me draw some of these veins very big. I want to draw them big so I can further highlight what I'm saying. Okay, so there it is. Let's draw it very big. And let's draw, you know what? Let's draw in black the coronary arteries. You see right and left. Here's the left one. Here's the left anterior descending artery. Here's the coronary artery. Okay. So let's go ahead and look what happens, okay? Let's see what the nitrate does once we take it and it causes relaxation, okay? Now we said before that it does relaxation of any smooth muscle, mainly the blood vessels, and it does relaxation more on the veins rather than the arteries because it has more guanine cyclase than arteries. But it still has an effect on arteries, but mainly on the veins, okay? And what it does is that, first of all, let's look at I'll tell you what it does. But first, let's look at the structure of the vein to understand this. So the veins, if you want to do, you got to know a little bit of a small difference there is between veins and arteries in their structure. And what happens. So you guys know that when there is, of course, this is an artery and this is a vein. But anyway, you guys know when there is vasodilation, there's an increased blood flow in the arteries, right? By sympathetic system. Let's say, for example, when there's vasodilation, there's going to be decreased pressure and there's going to be increased blood flow in the arteries. Because the arteries, they're thick and they're elastic wall, and their main goal is to be as a pressure reservoir. Their main goal is to push the blood. They don't keep the blood. Tamam? They're there to supply the blood get the blood and supply it to whatever organ it may be, any tissue, whatever it may be. And they're very strong. Okay? While the veins, on the other hand, they are known as what? Let me type it in blue color. They're known as blood reservoir. And they're known as capacitance vessels. Capacitance means storage. Now you see, the thing is about veins is that they're very fragile. I mean, compared to arteries, they have a thin elastic wall, and basically they're known as blood reservoir because they have the tendency to hold more blood than arteries, let's say 60 to 70%. Now, is there stasis of blood? No, but it's just going to flow much more slowly, okay? Much more slowly. Carries usually deoxygenated blood in the form of pulmonary veins, oxygenated blood, okay? Now, here's the thing. When there is vasodilation, we said before there's going to be increased blood flow in the artery, right? In the veins, because of its capacitance, because of its ability to carry more blood as a blood reservoir, you see what's going to happen when there's vasodilation in the veins, there's actually going to be decreased blood flow. Because when you do vasodilation and you decrease the pressure, all this blood, the veins is pretty much going to keep a lot of it. It's going to keep a lot of it. Blood will still flow, but it's going to be much, much more slowly. So it's going to be decreased blood flow, decreased venous return to the heart. The venous return meaning the blood that's returning from the vein to the heart. But in vasodilation in the arteries, it's the opposite. When you do vasodilation, there is increased arterial return. Because of their structure, when there's vasodilation, they're going to do the opposite thing. That's why in the sympathetic system, what's going to happen, let's say, and you have to do an exercise, your artery is going to be doing vasodilation and your veins is going to be doing vasoconstriction. And vasoconstriction is the only way to pretty much squeeze whatever blood it may keep to go out, to flow out and increase the venous return. Okay? So we said before that vasodilation decreases the venous return, and it just so happens nitrates through the use of nitric oxide, through the synthesis of nitric oxide, will cause vasodilation and decrease the blood flow or decrease the venous return to the heart. And basically what happens is that now, let's say over here in the pulmonary veins, there's going to be decreased blood flow coming towards the left ventricle. And instead of saying decreased blood flow, we're going to call this preload. What is preload from physiology? Preload is pretty much end-diastolic volume. It is the volume of blood that remains in your ventricle before contraction. So we call this as another word for end-diastolic volume. And basically, in diastolic volume, as we know, 130 to 120 milliliters. The amount of blood that comes to the ventricle from these pulmonary veins is dependent on the veins. If they vasodilate, there's going to be decreased venous return. So instead of 130 milliliter, let's say you get 90, for example. Tamam? This is known as decreased preload, and it decreases the preload. Now, you also remember that it decreases the cardiac output. Remember cardiac output from physiology? The factors is stroke volume and heart rate. This mainly affects the stroke volume because decreased number of end-diastolic volume means when the ventricle contract, the stroke volume is going to be low. Tamam? The less end-diastolic volume, the less stroke volume. Tamam? Now, before I continue, why do we want to do that? Why do we want the nitrates to do that? Why would we want to decrease the blood flow? Why would we decrease the preload to the heart? What's the point? Well, the point is, as we said before, we want to decrease the oxygen demand. Remember, when a person has a narrow artery, when there's narrowing of the artery by any infraction or any atherosclerosis or any angina pectoris, here's the thing. What we want to do is have the oxygen demand decrease to be equal to the oxygen supply. So the way to do it is you decrease the amount of blood that comes towards the left ventricle. Now, if you remember physiology, basically when there is an increased amount of end-diastolic volume, increased preload, your myocardial fiber is going to stretch. Like a rubber band, it's going to stretch. Okay? Like these, like a rubber band. Now, I want you to think these rubber band is myosin and actin in the cardiac muscle. Like a rubber band, when you increase more blood to the ventricle, they're going to stretch. And when they stretch, they produce a tension. Okay? Now, here's the thing. The more you fill this blood, the more muscle fiber length is going to be stretched, the more tension is going to be produced, the more contraction your heart has to produce in order to excrete this end-diastolic volume. So, for example, we got 90 milliliter of blood. It's going to extract 60 milliliter. Let's say in another scenario, there was a 300 milliliter of end-diastolic volume to the ventricles. Okay? And let's say it had to extract 250. Here's the thing. There's a massive difference between 90 and 300 milliliters of blood coming towards the left ventricle. The left ventricle, in this 300 milliliter, basically it has to contract more because all this volume, it has to contract more. It has to consume more oxygen, more energy for more contraction in order to excrete 250 milliliter of blood. But if we decrease the end-diastolic volume from 300 to 90 milliliter, then the heart will contract less. The heart will not have, it will be stretched to a certain point, but it's going to be contracting less as compared to before. So it's going to use less oxygen consumption, less energy consumption, and basically what you're doing is that you're decreasing the heart's workload. You're decreasing its preload, you're decreasing its cardiac output, you are basically decreasing the heart's ability to use more oxygen, and therefore the oxygen demand is going to be equal to the supply. Tamam? And when it's equal to supply, there are going to be no angina pectoris, inshallah. Okay? This is a form of compensation. And that is the main effect. Okay? Decreased preload and decreased cardiac output, but this is in a normal heart, like people without heart failure. How is that? We will get into it later. Also, of course, it decreases the blood pressure, vasodilation, Shabab, vasodilation in the veins. Mainly, it will decrease the blood pressure. And also, another thing from physiology, improve the perfusion of subendocardial regions, because here's another thing as well, Shabab. When there's an increased amount of end-diastolic volume, we said it's going to contract more to pump out all of it, right? At the same time, when there's increased amount of EDV, your heart is going to contract more. And you guys remember from physiology the coronary arteries, how they get compressed during ventricular systole? Well, if you decrease the amount of end-diastolic volume, you're going to contract less. That means less compression of the subendocardial region, for example, or the coronary arteries. So you actually improve the blood flow. You improve the perfusion as well. Okay? So that's another very useful effect at therapeutic doses. Now, if we look at arteries as well, arteries, like in the coronary arteries, it will do vasodilation and it's going to improve the blood flow. And you'll see that some of these going to lead to increased blood flow. Again, any blood vessel that has smooth muscle. So it's not exclusive to the heart. So skin, for example, there's going to be blushing, right? There's going to be dilation of the cerebral vessels. Large epicardial vessels mean coronary vessels, and large collateral vessels. Okay. And these are at therapeutic doses. Now, of course, it acts on the large arteries, but as we said, less pronounced. Now, let's go at higher doses. Now, if you were to take nitrates at a much higher toxic dose, and you did that, right? Now, its side effects is pretty much the principle for any vasodilator drug. We said before it's going to do vasodilation, right? Now, what if it does way too dilation? There's way too much of an increase in vasodilation. The blood pressure is going to decrease to dangerous amounts. And this is bad because, for example, if there's vasodilation in these, let's say in the aorta, and let's say drop from like 80, let's say from 80 millimeter mercury drop to 50 or 30 milliliter of mercury. What do you think? There's going to be during the diastole, ventricle diastole. Now, we said the ventricle pressure during diastole is 0 and the aortic pressure will always be greater. So let's say it's 30. There's going to be blood flow, but it's going to be much reduced. And it's definitely not going to be sufficient enough for the heart. So what's going to happen? Your heart is going to try to bring this blood pressure back. And it's going to do so by the sympathetic stimulation. It's going to stimulate the heart. And if you remember physiology again, the indirect effect of sympathetic stimulation through beta-1 receptors activation will lead to indirect vasodilation. Yeah, sure. But it also is going to pump more and more blood to the aorta in order to restore the aorta, or the aortic pressure. Okay? And unfortunately, Shabab, you see where I'm going with this? At higher doses, this can undo its goal in the first place, which is to decrease the oxygen demand. There's going to be reflex tachycardia, and there's going to be reflex increase in cardiac contractility, so there's going to be increased consumption of oxygen, and what you've done is that you've literally undid its effect. So you should be very important when it comes to taking nitrate at a therapeutic dose. Okay? And this goes for any vasodilator. Other relaxations we've said before, it's relaxation of all the smooth muscles, so bronchodilators, some of the constipation, decreased platelet aggregation. Another thing that's very important, and it's also used for something that we know from rest block, cyanide poisoning. We can use nitrate for cyanide poisoning. How? We'll get into that, but it involves the formation of mesoglobin. Now, mesoglobin is obviously bad, oxidation of ferrous to ferric, because nitric oxide is still a free radical, and in high amounts, it could pretty much be a free radical and convert ferrous iron to ferric iron, and it pretty much gives the characteristic cyanosis, which is bad, right? No carrying of oxygen. However, mesoglobin also can be used for a therapeutic purpose. We could manipulate the side effect to be a good thing for cyanide poisoning. We'll get into that, but just know its action is also mesoglobin formation. Okay. Now, the rest of these slides is just pure memorization. Of course, bioavailability, blah blah blah, biotransformation, by nitrate reductase. The only thing I just want to add is that, of course, the bioavailability is orally low, except isosorbide mononitrate, which if you see, there's going to be a table of all the nitrates and the administration routes, and this drug right here, you can only take it orally because it has high amounts of bioavailability. Okay, that's the only thing I want to add. Sublingual, transdermal, And here's the tolerance. As I said, there can be formation of a tolerance to nitrates, and the reason there's tolerance of nitrates is that is due to the function of dosage and the frequency. When you take high amounts of nitrates and you do it at a frequent basis, eventually your body is going to develop tolerance to nitrates and also other compounds similar to nitrates, okay? Now, the reason could be possibly due to decreased availability of the tissue sulfahydryl groups. These tissue sulfahydryl groups, they're used in the two reactions. They're going to be depleted, right? And basically, you're going to inhibit its pharmacological effects. Now, the way to fix it is by undoing or decreasing the thing that created this tolerance in the first place. You decrease your dosage and you decrease your frequency. And this is known as nitrate-free interval. Basically, what you do is that you will take two drugs that last for a long time. Its duration is long. You pretty much tell the person the next day, I want you to take this nitrate drug at like 7 a.m. and don't take this drug till 7 p.m. right? For the next 10 hours. And in between it, you'll just take some other drug, okay? So you'll take two drugs and have it taken in two different intervals, time intervals, and you will keep going and going and going till tolerance develops. What happens is by decreasing the tolerance, through decreasing the dosage and the frequency, you're pretty much allowing for your body to be more sensitive to the drug, and you're allowing for your body to replenish its sulfahydryl group at the same time. Okay? So this can restore undue tolerance, my bad. And it can cause dependence as well. Drug abuse or dependence, in which if you use it for a long time, your heart becomes used to it, your blood vessels become used to it, and therefore when you stop using nitrate, you should do it gradually, because what could happen is that if you suddenly do, you're gonna have withdrawal symptoms basically if you stop using it, and this can lead to myocardial infarction, coronary artery spasms, vasoconstrictions, very bad stuff. Okay, so you should be very careful because it has a dependence effect. Here is the duration, as we said, and here this is all memorization, but you should know this table, of course, especially when it comes to treatment of angina pectoris, acute treatment, and chronic prophylaxis. And you could also add right here, other than nitroglycerine, you could just add also amyl nitrate as well. Same thing, except for isosorbide mononitrate, of course. So this is very important. Now, if you go to the next slide, it talks about its adverse effects, and some of these adverse effects are related to any vasodilator. We said that it does vasodilation of any smooth muscle, so in any blood vessel, right? So this can apply not just the heart, but the brain as well. Headache, dizziness, vertigo, syncope, all dilation or hypotension, flushing of the face. Flushing might not have blushing, palpitation from tachycardia, postural hypotension, palpitation from reflex tachycardia, my bad. Also, other adverse effects, muscoglobinemia, but we can use it for a therapeutic purpose. Withdrawal reaction, okay, that's the dependence part. And the drug abuse was amyl nitrate, okay? All these are to be memorized. As we said before, flushing of the face and all that due to dilation of like the pretty much the arteries in the face, okay? Now, if you look at the contradictions, and this is just lovely. I'm actually going to explain some of them, and they're going to make all sense, okay? So when I explain them, when you look at this slide again, you're going to be like, man, this is easy. Because if you know the contradictions, if you know their mechanism, then you immediately know how to revise it, how to retain the information for the exam. So the first contradiction is angina. Wait, angina what? Angina due to, what is this? Hypertrophic cardiomyopathy. So diastolic heart failure. We can use nitrates for systolic heart failure, and we can use it for diastolic heart failure. Okay. So how I'm going to explain this is that, first of all, there are two types of heart failure. There's something called diastolic heart failure. We're going to type it over here. And there's systolic heart failure, okay? Now, the difference between this and this is that, first of all, they both have the same thing in common, in which there is failure of the heart to pump sufficient amount of blood to itself, pretty much inability of the heart or failure of the heart to pump sufficient amount of blood, all right, to the aorta, for example. But the how they do it, how this occurred, is going to be different. There's one that occurs during ventricular diastole, and there's one that occurs in ventricular systole for systolic heart failure, okay? So let's talk about first the one in diastolic heart failure. So it tells you there's angina due to hypertrophic cardiomyopathy. So basically the heart, and this occurs due to myocardial infarction. So when a person has basically myocardial infarction and he recovered, okay, and let's say this person, the person recovered from a myocardial infarction and his heart is damaged, necrotic damage, fibrosis, and basically it pretty much cannot pump blood as well as it can. The ventricle is damaged, right, from myocardial infarction. Basically what your heart is going to do is going to try to compensate. And how, okay, let me explain again. Basically when myocardial infarction, in diastolic heart failure for it to occur, there has to be myocardial infarction. And when a person, let's say, recovers myocardial infarction, you'll realize like his left ventricle, for example, is going to be weakened. It can't contract as well as it can anymore. And thus, it's the pressure that it generates from weak contractility is not high enough or is not good enough than the one in the aortic pressure. Tamam? So what the heart does as a form of compensatory mechanism is try to increase the pressure in the ventricle. How? Well, it's going to do it through something called hypertrophic cardiomyopathy. There's going to be hypertrophy of the myocardium. Okay? Hypertrophy of the myocardium. Just like that. This is the myocardium and it hypertrophied. And what this does is increases the pressure in the ventricle so that the heart can pump blood sufficiently to the aorta. Okay, so this is a good thing. But here's the catch. It fixed this pressure problem. But now it doesn't have the contractility problem, but now it has another problem. It ran into another problem. So in diastolic heart failure, basically what happens when this hypertrophy of the myocardium occurs, you'll realize that the ventricle, it became smaller. The ventricular chamber becomes smaller. So when there is venous return, when there is end-diastolic volume, when there's preload, blood coming from the left atrium to the left ventricle, the end-diastolic volume will decrease. The normal is 120. Let's say this is 60. Because the ventricle chamber became small as a result of this hypertrophic myocardium. And this hypertrophic myocardium, we said, it forms a compensation from pretty much damaged heart from myocardial infarction. So what happens? Okay, this end-diastolic volume has decreased. It can contract fine. However, this is way too little blood to the aorta. And this occurs during ventricular diastole. So we call this process as what? We call this as diastolic heart failure. And what does it have in common? Why is it contradicted in nitrates? You guessed it. It decreases the nitrates decrease the venous return. And the problem with diastolic heart failure is that their heart, it cannot get enough blood. There's a problem with ventricular filling. There's too little blood. So all this nitrate does is that instead of 60 milliliter we said before, right? Nitrate come in, they dilate the veins, decrease venous return. So instead of 60 milliliters, it's going to be like 30. It's just going to exacerbate the problem even more. So we cannot use this for diastolic heart failure. But we can use this for another type of heart failure instead. And this type of heart failure is systolic heart failure. So we finished diastolic heart failure, by the way. Now, systolic heart failure occurs due to, let's say, dilated cardiomyopathy. Okay? Dilated cardiomyopathy. And basically, dilated cardiomyopathy basically means that the myocardium in the heart becomes damaged, necrotic from myocardial infarction, the same thing. And basically what happens is that these myocardium, let's say the myocardium was here, this part became necrotic, it disappeared, and what happened is there's going to be an open gap. There's going to be this huge space. But this space, okay, you might think, oh wow, that's good, right? Because now more blood can come in, more blood flow, right? Wrong. We said damage to the myocardium, right? Permanent damage. And that includes contractile cells. So basically, what happens is that when there is end-diastolic volume, when there's pretty much blood coming from the veins to the heart, to the ventricle, the end-diastolic volume will actually increase. Let's say 200. However, the problem is not in the filling, the problem is in the contractility. We said that this is systolic heart failure, it comes from myocardial infarction. Basically, when myocardial infarction occurs, there's going to be necrosis of the heart, of some of the myocardium in the heart. So there's going to be loss of contractile cells, and there's going to be decreased contractility. And basically, some of the myocardium degenerate, and there's going to be this dilated cardiomyopathy, DCM. Okay? There's going to be increased volume or increased end-diastolic volume. However, the problem is now the heart cannot pump the end-diastolic volume that it received. It cannot pump, for example, 107 milliliter. It fails. It has weak contractility. So there's going to be failure of the blood to conduct or pump sufficient amount of blood to the aorta and to the heart and to the rest of the body. And this occurs during ventricular systole. And we call this process as systolic heart failure. But here's the thing, this is where we can use nitrates, and this is for the same reason. It's vasodilation on the veins, venous return. It decreases the venous return, decreases the end diastolic volume, becomes, let's say, 100. And basically, what happens is that you're pretty much allowing for this weakened ventricle to take a break. Instead of 200, you will take 100 milliliter, and your contraction should be sufficient enough for this amount. So now your weakened heart can actually contract sufficient amount of blood. Now, people with systolic heart failure, Shabab, it already has a terrible cardiac output to begin with. Very low cardiac output with systolic heart failure, and very terrible stroke volume, right? Nitrates can basically increase it. It can basically increase it in comparison. So in a person with systolic heart failure, we can use nitrates, which can decrease the end diastolic volumes through decreasing venous returns, through decreasing vasodilation. Let the low amount of blood come in. The heart can contract this amount of blood. There's going to be efficient ventricular contraction, and basically, in comparison to before, you are actually increasing the cardiac output through increasing the stroke volume. Tamam? So nitrates are contradicted in diastolic heart failure, this one, but you're going to see in the therapeutic use, it is used for systolic heart failure. And everything I explained in diastolic heart failure, systolic heart failure, you're going to see it as well in beta blockers and calcium channel blockers. What are the contradictions, and what are the indications? Okay, so we're going to delete some of these. This is the first one. Say you should type here in diastolic heart failure. And then the next one is constrictive pericarditis. Basically, let's remove some of these and just draw the pericardium. Okay. Just imagine the pericardium in green. Basically, when there's inflammation of the pericardium, this will lead to accumulation of pericardial fluid. And accumulation of pericardial fluid is going to lead to what? Cardiac tamponade. Basically, this in pericarditis, there's going to be accumulation of fluid around the pericardial fluid. This will lead to cardiac tamponade. And what is cardiac tamponade? Compression of the heart due to accumulation of fluid in the pericardium. Okay, and when there is and basically what this fluid does is that it surrounds the heart, right? And it compresses it. It pretty much, what it does is that it compresses the heart even more. It compresses the heart. It cannot contract as it can. And here's the thing, right? It pretty much affects which area? The left atrium even more. It pretty much inhibits the left atrium from getting small amount of, not small amount, but getting the necessary amount of blood from the veins. And the reason why nitrates are basically contradicted is that they decrease the venous return. So there's going to be even less blood coming to the atrium. Again, cardiac tamponade compresses the heart all over the place, but it's going to compress the left atrium even more, preventing the left atrium from what? From sufficient amount of blood, taking sufficient amount of blood. And basically what happens, so because of what? Because it's increasing the pressure in the atrium. So there's going to be decreased blood as a result. Okay? And basically, this nitrate will make it even worse. There's going to be even less blood coming to it. Okay? So another one could be constrictive pericarditis. Another one is increased intracranial pressure. And of course, when intracranial pressure occurs, basically when somebody has a head injury or cerebral hemorrhage, he's going to have not vasoconstriction, but he's going to have his veins, let's say, he's going to have his veins dilated. And basically there's going to be hemorrhage and whatnot. And we shouldn't give nitrates because we said nitrates can do vasodilation in any blood vessel, including cerebral veins. So what kind of nitrates does is that they can make it worse. They may increase the intracranial pressure. And what do we mean by intracranial pressure? I mean pressure within your skull, because there's dilation of the veins containing whole amounts of blood. Tamam? And nitrates just what it does is that it makes vasodilation even more, increase more pressure in your little brain. Okay? So we cannot use it for increased intracranial pressure. Of course, we cannot use it in somebody with severe hypotension. We cannot use it in severe hepatic disease because the metabolism of nitrates requires the liver to be functioning. We cannot use it in hypovolemic state. Hypovolemic, what it means is decreased blood volume. And when there's decreased blood volume, what's going to happen is going to be decreased pressure, right? You give nitrate, what's going to happen is going to decrease the blood pressure even more. There's going to be severe hypotension. So in somebody who's hypovolemic state, we cannot give him nitrates. Okay? We cannot give we cannot give nitrates to a person with hypothyroidism. Pretty much one of the hormones, I believe T3 and T4, I think it's T3. One of them is a vasodilator and it causes hypotension. And when pretty much when there's accumulation of T3 is going to be causing hypotension through vasodilation. And if you give nitrates to this to a person with hypothyroidism, it's going to make it even worse. And the last one, and that is the most important, is drug interaction with a Viagra drug known as sildenafil. Now, the reason why you shouldn't give sildenafil is that it will cause prolonged hypotension, very life-threatening hypotension. Why? This drug, Shabab, remember when I said that nitrates, they synthesize CGMP in the end, right, in the smooth muscle? Well, the CGMP is going to be inhibited. It has an inhibitor that blocks it, known as CGMP phosphodiesterase 5 inhibitor, okay? And this phosphodiesterase 5 inhibitor, it inhibits the cellular GMP to pretty much stop relaxation. What this drug does, sildenafil, is that it inhibits the inhibitor. Sildenafil inhibits the inhibitor. And this basically means there's going to be this pretty much means the CGMP is going to be roaming around, and there's going to be constant vasodilation, constant hypotension. And this is very life-threatening, which is why we should not give sildenafil to a person on nitrate medication, okay? Or if you're using sildenafil, one of them, same thing. So these are all the contradictions. I explained every single one of them, so that when you read it again, it will make everything's gonna make sense, okay? Therapeutic uses, of course, angina pectoris. Here's the treatment of the acute and chronic prophylaxis. When you want to use acute attack, use a drug that has a very quick onset. Just compare it to the table above. Prophylaxis, so you want to use a drug that lasts for a long period of time. And you can use nitrates for all types of angina. Some of them may not be the treatment of choice, but we can still use it. Like, for example, Prince middle vein angina. We said before that Prince middle vein angina problem with the coronary arteries, its main effect is not on the coronary arteries, but they can help in the treatment of it. Alright, we can use it in stable angina, of course, decrease the oxygen demand. Unstable angina, pretty much all of it. Demand, supply, decrease platelet aggregation. Why decrease platelet aggregation? Remember, unstable angina, atherosclerosis with partial thrombosis. You want to inhibit this thrombosis. Alright, that's a part of it too. And of course the other two factors. It's uncertain, but we can say all three of them, okay? And of course we said this before when we explained it, how the high dose may cause undesirable effects, which is reflex tachycardia, reflex increase in cardiac contractility, undo its goal, okay? And other than angina, this is what I meant in heart failure. This is everything I explained. With systolic heart failure, the decreased preload lowers the ventricle filling pressure, so allowing a more efficient ventricular contraction. Of course, also another thing is that if there is decreased amount of EDV, always remember there's going to be increased perfusion of coronary blood flow, because there's going to be less compression of the coronary arteries. So I'm going to keep in mind. Okay. And also we can use this for pulmonary congestion that comes from heart failure usually. Pulmonary congestion, when there's accumulation of pretty much fluid, pulmonary edema, basically. So pretty much have a blood vessel attaching to the lungs, okay? With the alveoli, there's going to be accumulation of fluid, right? Pulmonary edema. Basically, what nitrates can do is vasodilate the veins. I know it's in red color, but just imagine it's the veins. They can pretty much vasodilate the veins and basically pretty much force somebody's blood to go. Pretty much force somebody's blood that's pretty much being congested in the lungs, force it to pretty much go in front. Alright? Pretty much move it away or redistribute it away from the congestion. Okay? So we can use this for pulmonary congestion. We can use this for systolic heart failure. We can use it for angina pectoris. We can obviously use it for myocardial infarction. It can help. but mainly we use it for heart failure, hypertension, but it can be used for myocardial infarction. And this is the part where it is very unique, is cyanide poisoning. Remember cyanide poisoning from rest block? Basically, how it relieves cyanide poisoning is that you give both of these two drugs, amyl nitrite and sodium nitrate. Why? You want high amounts of mesoglobin for now. And what this high amounts of mesoglobin, what they're going to do is that they're going to form a complex. They have this mesoglobin, it has a high affinity to cyanide ion. So it's going to form a complex to it, and this complex is going to be known as cyanomesoglobin. When it forms this cyanomesoglobin, you will inject another drug by IV, which is IV sodium thiosulfate. This IV sodium thiosulfate will pretty much convert this complex into cyanomesoglobin into thiocyanate and mesoglobin, which is harmless and easily metabolized, by the way. And this fixes the cyanide poison. Okay, so this is going to be more increased oxygen supply. No more cyanide poisoning. Hooray. Alright. So these are the therapeutic uses, and we have finished everything there is to know about the nitrates. It has 4 therapeutic uses. Go very carefully on them. Just remember pulmonary congestion as well. It's not written, but use it for pulmonary edema more like. Okay. And oh my bad. Let me go proceed. We talked about therapeutic uses. We talked about its contradictions, adverse effects. Talked about pretty much duration, form, tolerance, dependence, pharmacokinetics, all of it. For nitrates. The next one is beta blockers. And for beta blockers, I'm going to make a separate video on it so we don't get confused. Separate video for beta blockers and a separate video for calcium channel blockers, okay? So this is it.